Improvement Scotland. And welcome to this, the fifth in our exciting lineup of QI Connect WebEx sessions for 2017. As you know, QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the field of improvement, innovation and integration. We have designed these sessions to be short, accessible and recorded to allow access at a time that suits you. I'm now going to pass you over to Jennifer, who will say a little bit more about the technology so that we can get the most out of today's session. Good afternoon, Jennifer.
Thanks, Brian, and good afternoon to everyone on today's talk. I'm just going to go through a quick couple of housekeeping slides just to get started on how to use WebEx. If you could please use the chat function that you see on the right-hand side of your screen, and I'll talk you through that in just a moment. And if you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the events manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be a fun, interactive learning experience. So we do encourage you to use the chat function to share any questions, comments or ideas throughout today's talk. And there will be an opportunity for Q&A at the end of the session. So if you want to be involved in the conversation, if you could just click on the chat icon circled in red here, select all participants from the drop-down menu, type your message and then click send. And just to flag that we will also be sharing hyperlinks within the chat function today to any resources mentioned by our speaker or throughout the conversation. And of course, please feel free to share any resources that you are also aware of. So we did promise a fun, interactive session. We're keen to find out where you're joining us from today, and we're delighted to have such a global audience. If you could please select the annotation tool that you see circled in red on the screen here, and then click on the arrow icon, again circled in red, and then click on your location. We know that there can sometimes be a slight delay with colleagues joining out with the UK, so just hold on. So welcome to everyone. Hi to Sophie joining from the Health Foundation.
Great to see so many people joining us, and thanks for joining the chat box as well. Everyone's giving us weather watcher reports from across the country and beyond. Great to see Marie Patterson up in sunny St Andrews. Welcome to the call. And welcome to Chelsea over there in Canada, Patty Webster from the Eastern Seaboard. You can let us know how the weather is where you are in the chat box also. We're just so delighted here in Scotland to have sunshine that we're celebrating it. Jennifer, thank you very much for the introductions. And it looks as though if we keep on with these arrows, Scotland might just tip up.
I know.
Tip over. We know we've got colleagues from elsewhere, and we'll come on to them just in a moment. But welcome to all of our QI Connectors this afternoon. And the QI Connect goes from strength to strength. Welcome, Claudia. We now have 572 organisations joining in for QI Connect. And just before we go much further, and I tell you more about those organisations, we always have, as you know, a wonderful competition here just to keep us engaged. So again, today we have amazing 51 countries joining us today, and some new organisations from one particular country. And when I call out the country, if you can reach that flag of that country with your arrow first, then there's an amazing prize for you. And the country we're going to go for today is Qatar. Rio de Milo. Welcome and well done, Ria. Welcome to QI Connect, and well done. That is indeed the flag of Qatar. And we will make sure that you get the, well done Alex, you got there in the end. We'll make sure you get your wonderful prize. So as usual, you'll get the QI Connect mug from Jennifer, and you'll also get a copy of a wonderful book, and we'll come on to that just in a moment. That's well done again, Ria, from Public Health and the NHS 5. Well done today. And just to prove that people do actually get their mugs, we're absolutely delighted that Fiona Montgomery, head of the Leading Improvement Team at Scottish Government, who won a mug last month, has received her mug. We've also sent a mug to Dr. Tasu Conway in the Queen Margaret Hospital in Tuvalu in the South Pacific. We haven't heard back that he's got his mug, but we'll be checking in and letting you know in future episodes of QI Connect. You're very welcome to your mugs. And the 572 organisations, we have amazing logos from each and every one of those organisations. And these now run to 18 pages of logos. And those of you that have been with us since the beginning will know that we started just with one page. And we're now, look at these wonderful logos from all over the world. You're most welcome as QI Connectors. And we're always delighted to say that the whole of the NHS in Scotland that joins us for QI Connect, always delighted to have the whole of the National Health Service join us. And of course, we always shout out to our universities, and we now have 56 universities who join QI Connect on a regular basis, and you're all very welcome. And particularly our two newbies to QI Connect, the University of Cambridge and the University of Abertay here in Scotland, you're both very welcome. And other organisations joining for the first time, super to have the Canadian Foundation for Healthcare Improvement. We had their Vice President of Programmes, Stephen Samus, with us here last month. It was absolutely wonderful to hear of the great work going on across Canada. True Innovations, again from Canada. We have Dumfries and Galloway's Council joining us for the first time. You're very welcome. The UK National Council for Palliative Care. We have the Sidra Medical and Research Centre from Qatar. We also have the region of southern Denmark joining us. You're very welcome. And the Newcastle upon Tyne Hospitals, along with Nutricia, who are an organisation here in the UK. You're absolutely delighted. We're delighted we've put the logo of Edinburgh Zoo because there's a group of GPs, a GP cluster as we call them, with Ian Kelt, who's a partner at Ladywell East Medical Centre in the NHS Lothian. And they call themselves the Zoo Cluster because they work in the area of Edinburgh Zoo through in Lothian. You're very welcome to QI Connect for the first time today. And of course, we record all of the sessions, as I mentioned at the top of the hour. We record all of the sessions so that you can use them time and time again. And thanks to Carmen Forrest here in Healthcare Improvement Scotland, who's now reorganised our library to make them even more accessible. So super to hear of all of your activities reusing these wonderful resources. And a shout out to the International Society for Quality in Healthcare, who continue to use QI Connect as an approved resource within their fellowship programme. And a wonderful shout out to the Health Foundation and the Q Initiative, which aims to connect people with improvement expertise across the United Kingdom and beyond. For those of you that don't know the Health Foundation, it's an independent charity committed to bringing about better health and health care for people in the UK. NHS Improvement is responsible for overseeing foundation trusts, NHS trusts and independent providers in England, and they're working very closely with the Health Foundation around the Q Initiative, building capacity and capability in quality improvement. Delighted to have them as a key partner. And remember to tweet as you learn. We're always delighted with the Twitter activity, and I hope today is no different. This is the QI Connect small but perfectly formed team. You've heard from Jennifer here in the studio. We also have Michelle De Felici. Carmen Forrest is working behind the scenes on all the administration and certification, and of course our wonderful Twitter analytics led by Alex Sterling. So great to have that small but perfectly formed team together. So everyone is very welcome to QI Connect. And by way of introduction to today's session, I just wanted to flag up the kind of background to today's QI Connect speaker. Many on the call know Dawn Berwick, an international leader in improvement, and Dawn gave a wonderful speech at the International Quality Forum in Gothenburg last year in 2016. And in that speech, he called out these 6 books, and he offered us advice that to orientate us through our quality improvement journey, we should consider reading each and all of these 6 books, bringing a range of disciplines to the study and practice of improvement. And in fact, he went so far as to call out the first book. He said the first book to read is The Design of Everyday Things by Don Norman, because it's so much fun. He went on to say that if you read this book, you will change the way that you think about causes. It's a front door book to systems thinking. It's just wonderful. On the back of that glowing endorsement, then I'm delighted to say that our QI Connect speaker today, we've always aimed to push the boundaries and seek blow your socks off speakers. However, today, I believe that Jennifer and the team have excelled themselves. Our QI Connect speaker today has a long and distinguished career ranging from engineering, psychology, cognitive science, and other scientific endeavour. A leader in user-based design and technology, Don Norman was Vice President of Advanced Technology Group at Apple. Don is now the Director of the Design Lab at the University of California, San Diego, and is widely regarded for his expertise in the fields of design, usability engineering, and cognitive science. We are absolutely delighted to welcome Don to today's QI Connect. Good morning. Good afternoon, Don.
Good morning for me, good afternoon for most of you in the UK, and I don't know what time it is around the world, all times. Anyway, I'm delighted to be here, and yes, I had a lot of fun sliding down that slide. That's the Epic Games company in North Carolina that if you're a game player, you've probably heard of Epic Games, and it's a fun place to visit, as you can see. I've been asked to talk for about 15 minutes because what I wish to do is introduce the approach that we are taking here in San Diego and then leave it open to discussion. We've established the Design Lab, and my goal is that this should be one of the major centers in the world that looks not at traditional designs of little, devices and products, but rather at what we're calling complex socio-technical systems. And we focus, of course, on the people side, the human side of these complex systems, and one of those complex systems is healthcare. So the laboratory is divided into centers of excellence, and the largest center at the moment is indeed the Center for Healthcare. So I'll give you a bit of the philosophy that we use and then the kinds of projects that we are involved in.
Text message.
Sorry about the telephone. Text
message.
That's not a bad example, though. You see, I'm sitting here in front of my computer, and I have 2 large screens, and it took me a while to figure out how to connect up with WebEx and the telephone, but that worked. But there's all sorts of other things that are happening, and so I have a nice telephone system, and that every time I get a text message on my cell phone, it broadcasts throughout the whole house. It rings and says text message. And so that, first of all, interferes with this talk, but it's not a bad example of what goes on in healthcare. Healthcare was never designed. Healthcare sort of just happened. We started off with basically a physician who would take care of a patient, but over time we had specialized centers, we had hospitals, then we had specialties in medicine itself, and pretty soon we had multiple specialties and multiple clinics and multiple testing sites and multiple kinds of tests to be performed, all at different locations, and many kinds of imaging methods, and it kind of works. But it's all sort of ad hoc, and it's different in every single location. And that leads to great difficulties. And we'll come back to that in a minute. The philosophy we follow is, we call it people-centered design. And it's really pretty simple. When we are given a problem to look at, our first response is we do not solve the problem that we are asked to solve. Invariably, the problem that is stated is not the real problem, it's the symptom. And so the first thing we do is say, well, let's try to understand what's really going on. And what we do not do is go and ask people. Instead, what we do is we go and watch people. So, for example, we were asked to work in the emergency department at UC San Diego to help improve the care for the elderly. And what we did, therefore, was hire an anthropologist, train her, and let her go out and simply watch what happened in the emergency department. Now, it turns out that the University of California has 3 hospitals and 3 different emergency departments, and they're all run by one person, Ted Chan, who's the chair of the emergency medicine department at the health department at the medical school, but also head of the emergency department's clinics. And despite the fact that it's one person with one philosophy, each of these 3 clinics works quite differently. And it has to do with their different locations and different history. One has been around for about 40 years. In California, 40 years is a long time. And another one has been around maybe 10 years, and the third one has just opened up, and so it's only been around a few months. Then we actually went and looked around the country. So we selected a bunch of emergency departments that had specializations for the elderly, and we spent several months visiting each of these departments and trying to watch how they were organized and how they handled things. One of the issues, by the way, which I've tried, this actually the slide that's in front of you illustrates, is what does this word elderly mean? It's really the wrong word, because the concept that an emergency department that's specialized for the elderly means it's specialized for people who, they're old and feeble and they get lost and confused and they stumble and they have trouble walking or lifting, sitting up and so on. And no, then why call them elderly? Call them confused or call them problems, people with, basically name the problems that they have. Because, well, take a look at that picture. That's me. I'm 80 years old. Am I elderly? By all definitions, yes. Is that your typical picture of an elderly person? The point is that I know people who are 80 and who are 90 who are much more flexible and able and athletic and rational than people who are 20 or 30. And so one thing we are trying to do is understand why we are picking up on the elderly. Why not design this for people with difficulties, with impairments of all sorts? That's one issue. Second issue is that the emergency department is rather chaotic because basically there are a bunch of physicians and technicians and nurses all waiting to serve you. And when there's not much activity, they don't have anything to do. And then when problems come in, they rush to serve you, and if problems come in faster than they can serve, then there's a waiting list of patients. So sometimes we have patients waiting to be served, and sometimes we have physicians waiting for something to do. And it's very peculiar. They can't count on anything. They never know what's going to happen. So it's very chaotic, and it can be very stressful. And many people who work there love that nature of always dealing with the unexpected and the high stress. On the other hand, we're also working with cancer patients, and in particular with those who are being treated by radiation. So it's a radiation oncology center at UC San Diego. And once again, we have 3 different locations. They're not the same locations as the emergency departments. And the procedures are somewhat different, But the contrast between oncology treatment and emergency department couldn't be greater. In the radiation oncology center, patients are seldom in an emergency. You don't have to do something within the next 5 or 10 minutes. They are scheduled. Physicians can come in early in the morning, work their day, and go home at night. Seldom are they called in the middle of the night for some emergency. Everything is scheduled. And there's a wonderful diagram which they have drawn showing its boxes and arrows, and you probably all use similar things, showing how the patient comes in, and then we do this following interview, and then we send them there, and now we do this test, and then we send them there, and then they go home, then they come back. And the point is, each little box says, here's what happens, and then there's an arrow saying, and this is the next box where they go to. Well, we've been looking at that. Those look really nice, and they say, wow, this place really knows what it's doing. It's very well organized and very well structured. Until we started looking at the communication that went on between one box state and the next box state. And the communication was often faulty. And so where does that communication take place? Where is it shown? Oh, it's inside the arrows. Nobody talks about what's inside the arrows. You draw the arrow and you say, hey, you're admitted, and now you go talk to the oncologist, and then you talk to the radiation therapist and the dosimetrist and the technicians and the oncologist, et cetera. No. You have to pass your file. You have to pass all of the information about your history. You have to pass the diagnosis, and better yet, you should pass people's hunches. Hunches. That is to say, the oncologist makes a diagnosis but isn't completely convinced, and they have in the back of their mind some, we ought to check for this, and I really worry about that, and they don't write it down in the medical record, and so that's not inside the arrow. On top of that, things aren't labeled properly. So we talked to one person whose job was to take all of the imaging, MRI, CT scan, X-rays, superimpose them, combine them together for the single patient, compare it with the prescription, and make sure everything was in order. And he was doing many patients at the same time, and we said, well, that's interesting. How do you keep track of which ones go with which patient? And his answer was, sometimes I have to guess. Again, what was going on inside the arrows? So a lot of what we do is watching, trying to understand what goes on, trying to figure out what the fundamental issues are. When we think we understand, then we bring everybody together, we try to explain what we've observed, we talk about the analysis, and then we go through a second phase, we try to think of things that we might do differently. And then we try it out. We never believe we have an answer. We always know that our first answers are going to be wrong, especially with these complex issues. So as we slowly are making small steps, small increments, and small tests, with complex systems, you cannot sit back and say, I understand, here's how we should structure it. It's too big a jump. You have to do it through small incremental steps. And that's a lesson that's been learned over and over and over again in many different disciplines. Do it slowly, do it incrementally, always be testing, because, in fact, in the time it takes to make major changes, technology is going to change, the procedures will change, all sorts of things change. And so it's very important to be always observing. So the things that we are working on are cancer, with the cancer clinics, and together with the National Cancer Institute, which is part of our National Institutes of Health. We are working on the emergency departments, as I said. We're also working in radiology, that we've been observing some operations. And it's interesting because if you're doing an MRI scan of a patient, the radiologist then is given something like, could be given 5,000 images. And the radiologist goes up and down through them, forming a 3D image in their mind of what the slices are showing. And then also trying to maybe take a previous MRI scan, several months or years previous, and doing the same thing and now comparing the two to try to understand what the differences are. Even though they're done often with a different angle and different dimensions and even different equipment, it's difficult. They say, oh no, we can do it in our head, we've got the answer. But when they have the answer, they have to transmit it then to the primary physician, and in the case of surgery, to the surgeon. And the primary physician needs a different kind of information. They can't go through 5,000 MRI scans and understand it. What they really need is a three-dimensional model of the inside of the body showing this is where the issue is. What the surgeon needs is something different, something to plan the surgery ahead of time. During the surgery, the surgeon also needs information, but very, very different. Because now the surgeon is inside, and suppose let's look at abdominal surgery, which is what we looked at. The surgeon is inside the abdomen and something unusual is there, and the surgeon wants to take another look at what the scan showed. But again, that's a very different kind of image. And as you try to explain to the patient and to their family, they need other kinds of images. So what we're trying to do on radiation is to say, what is for radiologists, what is imaging going to look like in the 21st century, where we need activity-specific images. So the very same patient and the imaging, the information will be different for the different specialties and be different for the patient and their family. And not only that, but might even be different for any given specialty depending upon what activity they happen to be involved in. So that's a very big project that we are just embarking in, together with, of course, the chair of the radiology department at our health school. In all of this, our focus is on observing and making sure things work for the activity, but we're also very concerned with the fact that this system was not designed that we draw very nice diagrams which don't show everything that goes on, that the electronic medical records are basically unusable. Everything you ever wanted to know is often in those records, but so what? It's not presented in a way that's intelligible, that helps you quickly make your decision. Again, the visualization there is very bad. And it's often not complete. These wonderful diagrams show what happens when everything works, but well, in the complex radiation oncology clinic, not everything is always working. The radiation machines are $10 million a piece. They're very complex. They have to be calibrated. They include a linear accelerator and very precise calibration methods, both in aim and also dosage. And when they don't work, well, that diagram is wrong. And people are very good at moving around when things are not working right, but then that means our explanations are wrong. And the number of specialties is astounding. In radiation oncology, there are over 20 specialties that get involved in the treatment of a patient. Quite often, the time between a patient noticing a problem and the first treatment can be 6 or 9 months, and most of that time is spent with the patient waiting for the next appointment. No activity, in other words. So that's our problems. Those are the ones that we are tackling. And maybe that's enough of a beginning to cause a conversation.
Don, thank you very much. You covered a whole range of examples there that really go to the complexity that's in our systems, from challenging the terms that we use and how we categorize patients through to how we try and simplify things by drawing them into flow diagrams. You captured a lot of activity on the chat box already. We're hearing from colleagues in New Zealand. David Grayson, Waitemata District Health Board in New Zealand, telling us that he has folks on his team that are studying the way that systems are working with people on the team, including designers and anthropologists on the team. So welcome to David. I think it's 3:30 a.m. where you are, David, in North Island. So welcome. Now listen, today I should have said that we've got a slightly different format for QI Connect. Given the breadth of Dawn's experience, we had a whole range of people that were keen to ask a question, and in fact we've created a wonderful panel today. We have Kat Macaulay, who's the Head of User Research and Service Design at Scottish Government. We've got Penny Pereira, Deputy Director of Improvement and the Q Programme at the Health Foundation. We have Manoj Kumar, who's a surgeon in Grampian here in Scotland and the National Clinical Lead for the mortality and morbidity work here in Scotland. And then we have two of the most enthusiastic improvers we have here in Healthcare Improvement Scotland, working in the field of dementia. We have Lynn Flanagan, who's our National Clinical Lead, and the team lead, Michelle Miller. So all of these folks have got interest in what you've been talking about, Dawn, and I'm going to invite Kat to open the questions. Good afternoon, Kat.
Hi, good afternoon. Good afternoon, Dawn. Good afternoon, everyone else. I'd be remiss if I didn't, before I ask my question, just add a little personal touch to the event. Dawn, my copy of your book is so old, it's actually called The Psychology of Everyday Things and not The Design of Everyday Things. And in fact, I tweeted a copy of it from my bookshelf yesterday, if you want to see the photograph. You were hugely influential to me. Back in 1994, I was studying a master's and thought I might become a programmer. I was looking for a career change. And it was on reading your book that I utterly transformed my thinking. Went on to do a master's and a PhD that blended design and anthropology, and all of that has basically landed me up where I am now. So I am hugely grateful to you and enormously delighted to have an opportunity to ask you a question.
Thank you.
And so my question is around that long history that you have in the industry. And as you've gathered, there's an enormous interest in health, in social care, in government and the public sector more widely, in Scotland in particular, around how design might help us with some of our huge challenges. As somebody who's really seen and often driven many changes in the way that we all think about what design is and how to do it, I'm wondering if you had any tips or hints or ideas for what helps people bring design ideas into an environment that doesn't have those at its heart already. How do we effect that cultural change? How do we move design more closely into the heart of our health and social care?
That's a difficult question because it's a question that deals with culture and the way that people have always been doing things. And quite often, and when things have been done this way for as long as people can remember, most people aren't aware that there really are alternatives, that this is not the way things have to be. And so how do you bring healthcare or the new methods of healthcare into not only healthcare, but also all the areas that surround it, social services of all sorts, is very difficult. I don't have an easy answer. In fact, I don't have any easy answers for any of these problems. One of my favorite quotes is from an American journalist of many, many years ago, in the 1930s, who said something like, "Every complex problem has a simple answer, and it is wrong." And that's a problem that we face, that it's quite often that people can look at these complex issues, or how do we integrate this kind of service with that kind of service, and think of a very simple answer. But if you can think of a very simple answer for a complex issue, you might realize that, well, maybe it isn't so simple, because if I can think of it pretty quickly, maybe thousands of other people have already thought of it and tried it, and maybe there's a reason why it isn't working. So these are very complex issues. One thing that we are trying is we're trying to do some citizen science. We are trying to, there's a large number of websites that have been developed. Things in the United States are called Patients Like Us and other similar things, where people can write, just everyday people can write down their problems and seek help. And then they help one another. And what we are trying to do is see whether we can actually make this into a source of information and interaction between experts and the everyday people. So what we hope to have is a set of experts who are reading these questions, mostly ignoring them, but looking for significant questions that may indicate, oh, this is a problem that we've never seen before. We don't have an answer. Maybe we want to put a team together to try to understand it and talk to the people who introduced it and see if we can get more information. Experts who can help guide. And one of the things that we were inspired by was, again, what patients did for themselves. Patients with diabetes discovered that there are several companies that make continuous glucose monitors. And there's a couple of companies that make insulin pumps. And they said, well, gee, if we could take the output of the continuous glucose monitor and just feed it into a simple little computer and then control the insulin pump, well, we would have an artificial pancreas. And they did that. They found a continuous glucose meter made by a company called Dexcom, which happens to be in San Diego. And they took it apart and they figured out how it worked, and they published the details on the internet. So anybody could sort of buy the continuous glucose monitor and sort of reprogram it to put its results out onto a website. And then they looked at another company's insulin pump, and they figured out how to control it from a website. And they linked the two, and so pretty soon they had invented an artificial pancreas. Now, you're not allowed to do that if you're a company, because if you're developing a whole new medical instrument that's really critical to some people's lives, you have to get approval of the government, the Federal Drug Administration, FDA. And that approval can take years, and it requires clinical trials, and clinical trials are incredibly expensive. Some of them cost up to $1 billion to run, and they're very difficult and time-consuming, and they often fail, not because the test fails, but because people can't maintain themselves in the trial for long enough, and they stop, and that destroys all the statistical rigor. So what we're trying to do is say, hey, if people can discover all sorts of new things or try out new things by themselves, isn't there some way we can introduce that into the medical community? And actually, the FDA in the United States is interested in that, trying to see how that will work. And we're very pleased that the company, Biodex, where the person took apart their stuff and published it all on the internet, instead of getting angry and suing the person, they hired the person and said, we want you to keep doing that because we're learning a tremendous amount. Now, that's a story about diabetes treatment, but it might very well be a partial answer to your question if you change the domains.
Thanks very much for that, Don, and thanks for that great question, Kat. And we'll look out that picture of you with the older version of the book. And now, by the way,
let me introduce. That book was written in 1988, and there's a new edition in 2013. The one that you were giving out as a prize is the British version of the new edition. There's an American version that's identical in every way except the color is yellow, and it's a different publisher. I won't. If healthcare is complex, let me tell you, publishing is complex. And how I ended up with 2 different publishers you wouldn't believe how hard that was. But the new edition, as I recommended, the principles are identical, but the examples are better, and I've learned a lot since 1988, maybe. And so there's new stuff in the new book.
That's great, Don. And in fact, we're taking Don Berwick's advice, and we're running the Berwick Book Group, and there's 20 or so of us here in this organization reading your book as we speak, which is wonderful. Now let's introduce our next questioner, Penny Pereira, the Deputy Director of Improvement at the Health Foundation. We've already seen in the chat box a range of Q participants. We've got Libby Keck, the Program Manager at the Health Foundation, and House Thomas from Thomas Design Limited, amongst a range of other Q initiative folks on the call. So good afternoon, Penny.
Hi Brian, hi Don. Thank you. This is it's really inspiring. Part of our interest in this at the Health Foundation is we're helping to establish a kind of Q improvement lab where we're trying to use design and improvement techniques to address some of the kind of complex challenges. We're at very early days, so we'll be learning from you with interest. I guess the Health Foundation's wider work also really supports your diagnosis that the system hasn't really been designed, really hard to navigate, really riddled with error. It feels a really sound kind of analysis. I guess given that complexity, my question is how you can get people to see the wider system and the underlying causes without becoming overwhelmed by that complexity. And then a kind of linked question, if we want to help people move faster in this territory, when is it possible for us to transfer ideas or interventions from one place to another? And when does the complexity of the systems we're dealing with mean that you have to start with a local diagnosis, understand the local situation, and improve iteratively from there?
Let's talk about the transferring of ideas and the trying out. We believe in always doing experiments, always trying out. The proper way, which we are also doing, is to once we truly try to understand the system, we try to think of this as a system. We actually look at the patient from when they are well until they are well. So that is, if they're well, they have a problem, they get diagnosis, they get treatment, maybe then they're released. If they're in a clinic or a hospital, they're released and they go back home. If they simply saw their primary physician, again, they go back home. But we want to look at that entire cycle and try to understand what goes through it. And, for example, compliance with medication and prescriptions is pretty poor. And so you have to include that in this whole cycle. But after you've understood the cycle, especially when they're complex, again, we like to do very small interventions. And so we often start the interventions even before we've understood the whole story. But it's really important to understand the whole story because you want those small incremental interventions to go in the correct direction. If you simply look at local things, you might actually try to correct something locally that makes it worse as a system. Optimization for the local often does not optimize the global story. So that's why, although we try to do small increments, we also try to have the system point of view, so we make sure that small increment is going to help the entire system. One thing we also look at is what the people do for themselves. A good source of understanding what ideas to try is to go look what happened. Go into the clinics and look at the notes that are posted. Look at the warning notes. Look at the way that people have their own shortcuts or their own special methods or how they overcome some difficulties or lack of information. Those are often really excellent sources of ideas that you can then transfer more globally. And the way we try to get people to accept it is, first of all, we try to make them invent the intervention that we're going to do. And second, after you've had a success, we try to publicize it so that other groups can see that this is working in some other clinic, which, well, they don't work the same way we do, but maybe that's an idea that we can use. People really don't like to be the first one often. They like to see, well, has it worked elsewhere? And so trying to demonstrate small successes is very, very useful. I'm afraid I lost track of your first question.
Simply that when we're asking people to understand the wider system, in our experience, that's quite a hard thing to do. It's quite easy to get overwhelmed by the complexity of it. So I'm just wondering what advice you'd give to people.
Well, we don't. Right. We don't show the whole system all at once. We really try to do it in small, manageable areas, which is actually, it's how we do science. When you do a scientific study of any phenomenon, the phenomenon is far too complex to be studied. So what we always look for is we want to carve it at the joints. And where are the joints? The joints are where there's there's a cohesive section that is a little bit independent of the rest. It has a minimum number of connections to other units. So we take a look at that, and that can easily be explained or shown to people relatively straightforward way. And that's what we do is we show people these little self-contained segments. And I haven't had any difficulty actually explaining this. It's, I mean, here's an example that I discovered. One of the complex things in a hospital is bed assignment. It never occurred to me until we watched people assigning beds. But when a patient comes out of the operating room, there's not a bed rep. There's no bed for them. And sometimes they have to stay in the recovery room for hours and hours and hours simply because there's no bed in the hospital. Now, there may be lots of empty beds, but they're not the ones that are, they're not in the wards that are suitable for this particular patient. And so it turns out to be very, very complex, and the people doing bed assignments have all sorts of workarounds. But once you start talking about the story, and like I just did, you begin to see yourself why this might be more complex than you might have thought and how to work it. By the way, in the emergency department, there's an area that we call limbo. Patients are in limbo. They went to the emergency department for help. They were treated. They were told they now have to be put into the hospital because it's a more serious issue. We can't send them home. And so the emergency department is finished with them. But the hospital, which is in the same building, mind you, the hospital can't admit them because they don't have a room for them. And so they're put in this little ward off on the side, and nobody owns them. That is, the emergency department is signed off, and the hospital hasn't quite signed on. And it has happened that they got forgotten. So, but again, that's really complex. But once I've described it that way, you say, oh, and you can begin to understand it.
Thank you very much for that, Penny, and thanks for that, Don. Steve Gilbert, who's in Townsville in Australia, crikey, it must be about 2 o'clock a.m. There. Welcome, Steve. Steve was saying that oftentimes people can be paralyzed by analysis of complex problems, and sometimes we have to get started with our best guess and have an open mind. We're hearing from a number of the chat box commentators about the challenges to have the time to think and design. But let's move to Manoj. Good afternoon, Manoj, a surgeon from Grampian who's been studying human factors for many years now. Good afternoon, Manoj.
Good afternoon, Brian, and hello, Norman again. Hello, Don, sorry again. My question pretty much follows on from colleagues who've already spoken, as well as some of the questions that come out. And first of all, I very much agree with your thoughts and comments that you've shared with us today. In your book, you noted in healthcare we focus on patient-centered care, which we all agree is great and is vital. But you also rightly noted the emphasis, unfortunately, often neglects the working conditions and needs of everyone else. Have you got any examples or anecdotes or tips on how we can perhaps have a better balance in ensuring we actually design our systems or services better for both the users and the providers? Thank you for that. Yes, I've been arguing against patient-centered healthcare for some time in our hospital system, and everybody listens to what I say, which is exactly what you said. Hey, if you really want a great patient experience, then, you know, the nurses, the technicians, the person doing the scheduling, the physicians, everybody has to have a good experience. So we have to look at the whole story. And they always say, yes, you're right. Oh, you're absolutely right. And then they go back to focus on the patient, because you know why it's a reward system? Because the patients sort of judge the hospital, and they put it on the social media, and there are all sorts of now rating agencies that love to rate the quality of hospital care, and they always do it by checking with the patients. And so that's where the focus is, because nobody gets rewarded for making the scrub nurse's job easier, or the technician who does the scheduling. And it's yet if the person who answers the phone and just gives you instruction on how to get to the clinic or about your appointment, if that person is stressed and difficult, the whole experience is bad. And it's very difficult, though, to get, because of the way that the reward structure works, It's all around the patient, and they very seldom go to the immediate cause. So they think that the solution to making patients happier is a more cheery waiting room and better magazines and colorful walls. And are those important? Well, yeah. But those, in my opinion, are secondary, not primary. And it's a difficult job. I don't have the answer, but I'm working on it.
Thank you very much, Don. Thanks for that, Manoj. So let's come to the Focus on Dementia team, and I think, Lynn, you're going to ask Don a question. Thanks. And Lynn, you might just be on mute.
Hello?
Hi, we can hear you. Fire ahead.
Hello. Hi, Don. Very modern healthcare environments, as we know, can be very confusing for people with dementia. What can we do to ensure that healthcare environments are designed with this in mind? Because I assume there's a bit of a tension between environments that look very efficient, i.e. are modern and high-tech, and environments that are understandable and not frightening for patients.
Unfortunately, that's not an area that I've looked at this point. So the dementia patients are going to be rather special. And one thing we do know about dementia is that, for example, if it's a memory impairment, a lot of the memory is in the environment. In fact, in the book, I talk about memory in the world and memory in the head. And so the patients within their own environment, like their home, often get along reasonably well because they've lived there for a long time. They rely upon the physical structure and locations. And now when we say, no, you can't live at home, and we bring you into a new living environment, their dementia gets worse because they no longer have the external cues to guide them in their performance. But that's kind of that's kind of the major contribution I make, which is not a very major one. So I'm afraid that we have not focused on dementia yet, and therefore I really shouldn't talk about it. I'm not expert enough.
Yeah. Lynn and Michelle, in the work that you've been doing on Focus on Dementia, how might you see design and user-based or human-based design help?
I absolutely think it's about making environments understandable for people, and very, very simple things can make a big difference. So, for example, being very aware about noise levels, making rooms understandable in that, if it's an area where people have to sleep, then that looks like an area that people have to sleep, and an area where we want people to eat, then again, is an area that looks like you have to, an area that you would eat. So sometimes very simple design techniques can really make environments much more understandable for people, and sometimes it's around making sure people are orientated as well, making sure that people have access to clocks or their watch, and again, sometimes it's confusing for people if they're in night clothes during the day. So sometimes very, very simple things make a big difference.
Yeah, and we're in Aberdeen for a reason today, because tomorrow there's a big dementia event happening tomorrow, but Lynn and colleagues up in Grampian have been doing amazing work within old Nightingale wards within Aberdeen Royal Infirmary, where they've actually been able to create an environment of reminiscence. So they've had day rooms which have been done up to reflect a more familiar environment, much more homely. So I would say not to be constrained by old Victorian buildings and Nightingale wards, but there are still opportunities to make such a difference for people with dementia, and we're seeing that through the visits and through the improvement work that we're involved in Scotland.
Thank you very much. Dawn, it sounds as though it goes to the kind of next stage of design in terms of the complexity of the human condition. I would just shout out the fact that if you read Dawn's book and look at Norman doors, you'll never look at doors the same ever again. Just something about the way the brain works. Now, just a shout out to the Improvement Club at the Golden Jubilee. and Akin and the team there, they've been following intently. One of the questions that's come from the chat box here, Dawn, from Stefan Siebert, who's a senior lecturer in rheumatology and a consultant in Greater Glasgow here, and also from Shelley Jeffcott, the strategy implementation manager at the ambulance service here, and also from David Grayson from New Zealand. They're all asking about how do you make time in a busy clinical environment to actually do the understanding and the thinking that you're describing is necessary to advance user-based design?
Well, the clinic is, right. In many cases, the clinic is stressed. Our various insurance companies insist that you can't spend more than, say, 15 minutes on a patient. You must also document everything you're doing, which my physicians explain it takes 20 minutes to document, 20 minutes out of the 15 that you are permitted. It's very difficult. But there are several different issues. First of all, to give the medical providers more time, if you take a look at the activities they do, they get in the way. And so there's a huge possibility to redesign the structure of electronic medical records, the structure of instrumentation, the structure of the patient questionnaires and the patient recording and doing the patient histories to make them a lot more efficient, but efficient in a way that is also more enjoyable and pleasant for everybody, because the patients don't like filling out long questionnaires and being asked the same questions over and over and over again, and the nurses and the physicians certainly do not like that. And so if we can make things, if we can redesign some of the equipment and procedures, we free up tremendous amount of time. The second is that for the design community, those of us who are trying to restructure and understand, so we try to be outside of that. So we are watching from on the side, and we're trying not to interfere. And our thinking then takes place when we go back to our offices and laboratories and do the Post-it notes exercise and try to understand what's going on. Where we have the time to think about it. And we bring in the medical professionals that we're working with, again, outside of their clinic where they have some time to talk with us. Some of them have such a busy schedule they can't even schedule coming to meet with us and do this. But we've been surprisingly successful in getting pretty senior people to come and spend hours a week with us restructuring. But you have to take it outside of the clinic. And within the medical clinic, that's where I think there's a tremendous possibility by just the way in which they do their work is so inefficient. It's just incredible. It doesn't take much expertise to sit back and watch it and say, why are they doing it that way? By the way, when you've said that, it still doesn't mean it's easy to fix. To restructure some of the interviews might require redoing a very large, complex computer program. So it's easy to find the areas, not always easy to fix them.
Dawn, thank you very much. That sounds like a good place to leave the call today. The QI Connect chat box has been alive throughout the whole call. I'd like to thank Kat McCauley, Penny Pereira, Manoj Kumar, Lynn Flanagan, and Michelle Miller, and most of all, a big thanks to you, Dawn. We'll follow up with some of the other questions. It sounds as though design and the human interaction and the complexity of healthcare needs to be an ongoing part of the theme of QI Connect. Just a big shout out, it's the Global International What Matters to You Day on the 6th of June 2017. I would be surprised if what matters to some people isn't just make it better and improve the design to do that. Big shout out to everyone involved in that. And also a big shout out to the rest of our amazing QI Connect for 2017. Wonderful discussion with Dawn today. Our next speaker is Anna Roth on the 27th of July. Anna is a wonderful speaker. She leads what's called a safety net public system in Upper Northern California. It deals with primary care, social care, hospital care, prison care, the integration of all of the above. Anna will share that with us. We're going to have an extended summer, a late summer, an early summer break, and we'll see Anna in July. And the rest of the speakers are, as you see there, we'll talk more about them at the next session. So a big shout out to Anna, a big thank you to everyone following us on Twitter, a big thank you to the team today. Here's QI Connect signing off until the next time. Thank you very much indeed.